Hello, everyone. Thank you for joining the Quality Provider Engagement Team's webinar today. Today, we're going to be discussing year-end sprints, care gap closures for CBP and HBD. We will begin promptly at 12 o'clock. For those of you just joining, thank you for being here with us today. We will begin promptly at 12 o'clock, so within 1 minute. All right, it is top of the hour here. Thank you very much, everyone, for being with us today. The Quality Provider Engagement Team is bringing you our last webinar of 2025 year-end sprint, care gap closures for CBP and HBD. We do have a full agenda today. The first thing again is welcome everyone. We will be going over some housekeeping, followed by two separate keynote speakers. Then we have a member of our Quality Provider Engagement Team to talk to you about CBP and HBD. We will share any updates as necessary, and then we will open the floor up to any Q&A. For housekeeping, just so everyone is aware, this webinar is live recorded with the attendance being logged. If you've noticed when you joined into the webinar, everyone is on mute. The Q&A section, being that you are on mute, is available to drop questions at any time throughout the webinar. We do have a member of our Blue Cross Blue Shield team here manning the Q&A section. And the slide deck for today will be available approximately 1 week after this webinar concludes. My name is Nina Davis. I will be your moderator today. We also have from the Quality Provider Engagement Team, Ms. Kelly Jacobius, who will be one of your presenters, Ms. Kylie Longoria, who will be in the Q&A area assisting everyone, and with, Ms. Lisa Zamorowski, who will also be in the Q&A section as well. Lisa is another one of our quality management analysts. Our first keynote presenter is Mr. Brendan O'Hara, part of our Blue Cross Blue Shield of North Carolina team. Brendan graduated from Albany College of Pharmacy, and after graduation, he began his career in community pharmacy, working in various positions from staff pharmacist to district pharmacy manager. He began here at Blue Cross Blue Shield of North Carolina in 2015 when he was hired as a clinical review pharmacist, and he now manages a team working on value-based programs, implementing pharmacy programs in health systems, provider groups, and most recently, community pharmacies to support quality measures and cost of care. Brendan is active within the profession with organizations such as the NCAP, the APHA, and the AMCP, and he has held national positions and state level positions as well. Without further ado, I'll turn it over to Mr. Brendan.
Great, thank you so much. Good afternoon, everybody. I'm glad to be able to kick off this webinar for us today. Really want to kind of jump right into it. And like Nina says, we've got a lot to get through today. So if I go to the next slide, Just level setting with everybody. Again, we know we're here today. We're talking about two very specific quality measures and the end of year push. But when we're talking about this, and I know you're going to see this numerous times through the presentation today, but when we're thinking about this, again, we're looking at controlling high blood pressure. We're really thinking about getting those measurements below 140 over 90. When we're looking at diabetes control, either GSD or HBD, we're really looking at those senior populations with an A1C or a glycemic status under 9%, and the rest of our population for a glycemic status under 8%. So just wanted to start off with level setting of really, I know you guys know these all too well, but as we're talking through this and we're using some of these abbreviations, want to make sure that we're clear with our conversation today. So on the next slide. When I think about this, I love this quote here because I think that it applies to so many different things. But it's tempting if the only tool you have is a hammer to treat everything as if it is a nail. And so when we're thinking about diabetes and we're thinking about hypertension, we really think about it from the standpoint of what are the ways that we can do it. Obviously I am the pharmacist, so pharmacy medications is a big part of the role, but it's not the only way we can do it. So we really have the opportunity for patient empowerment to make sure that they know about their disease state and they know the things that they do day in and day out and how that affects that, what modifications they can make within their lifestyle that will change things, and watching what they eat, decreasing caloric intake, increasing the ability for them to get out and get steps or kind of exercise. So all these things are ways to manage it. And again, this is all, it's all effort, but it's all things. And then when we think about medications, it's not just the right medications, but it is the right medications and making sure that the patient is taking those medications and they're adherent to those medications. But there's also a lot of other things. So again, a lot of what your team is doing is engaging, trying to work with these patients to improve some of those outcomes. But there's a lot of other people. So a lot of pharmacy work that does. We mentioned that our community pharmacy partners are already doing this. They're filling the medications and they have a lot of knowledge about the disease state. So don't forget to reach out to them to help support some of these needs. And then obviously other creative ways is some of those self-monitors. So we're going to talk a little bit about CGMs or continuous glucose monitors, but then also when we're looking at those measurements, our home blood pressure machines an option for the patient, and if we can have those available to them. So next slide. And so again, really just thinking about that additional toolbox and what we can do. Next. So important about this, and again, I always know that I'm preaching to the choir with this, but the patient empowerment is such a big part of the items in our toolbox. So again, helping them understand their disease state, helping them realize what they can do for themselves, helping them, be accountable to themselves, helping them find people who can help them be accountable, and really, the basic of this is realizing they have it. So many, and I'm sure that you guys find this, so many of our patients don't even realize that they have diabetes or hypertension. They went to the doctor, so much was going on, they didn't hear that diagnosis, and so they're on about things and just living their life without the medication. They can't figure out why they're supposed to be taking that. So know that they have the disease state, know about it, know how to manage it, know their numbers, know what an uncontrolled diabetes look like, know how that feels in them. And then obviously, again, as the pharmacist, there's so much that can be happening with medications. But again, it's much more than that. It's goal setting. So how do you understand your disease state and how do you set personal goals so that you can help yourself manage that? And that does require some changes. I mean, in order to get to the point where diabetes, sometimes it's genetic, sometimes there's other things, but usually there's lifestyle. And so we need to make some adjustments to our lifestyle to help improve that. And then another additional one that we have is again, I'm going to call out the More Than Script. There's a hyperlink in here with the slides that'll be shared, but that's their community pharmacy program where we're engaging 100 community pharmacists that also help with managing diabetes and hypertension, some of our overlap patients. So strongly recommend, again, when we're looking at all the tools in our toolbox, make sure that we're utilizing all of them. Next slide. So we think about medications. So how do we manage through medications there? What are some benefits? So by and large, our antihypertensive, so our blood pressure medications, the vast majority of these are largely generic. So on our Medicare population, a lot of those are part of those RAS adherence measures. So they are on that tier 6 with a $0 copay. And again, because most of these are largely generic products, we have those in tier 1 or 2 on our commercial tier. So they're in the lowest possible tiers available for those medications. Diabetes is a little bit different. So there has been some mainstream Medicare, some medications that we've had for quite some time that are generics, your metformins, your different areas. But we also see a lot of new medications like the GLP-1s, and there's different ways that these are managed. So brands, generics, we don't have a lot of restrictions on the vast majority. GLP-1s are really some of our big restrictions, largely are due primarily to make sure they're being used for diabetes and not the diabetic products are being used for weight loss. So definitely some opportunities here with some of the medications and how we're going to be able to manage those. And in a couple slides, I'll give you a little bit of visibility into some of the utilization of these. Next slide. So again, we're talking about medications, getting people on the right medications. I think it's always a great thing to call it the most expensive medication is the one that is not taken, because again, that costs the patient and it costs healthcare in general a lot because they've been identified as having a disease state, prescribed a medication, but they're not taking it. So in helping them take it, how do we decrease some of those barriers for those patients? A lot of our pharmacies are doing medication synchronization so they can have those medications all come due at one time each month or every 30, 60, 90 days, whatever it might be, but they can sync those medications up. That allows for an appointment-based model. So again, when we're trying to have those conversations about disease state management, when the pharmacist is able to look at all those medications being filled, they're having a clear visibility into the medications for that patient. Sometimes some of our patients with additional barriers may just forget about taking their medications. So there's dose packing where all their medications for the morning can be together, all the medications for the afternoon. And, pill boxes work great for this too, but some of our pharmacy partners offer, dose packaging that helps the patient kind of manage that as well. Obviously, for adherence measures, we're all quite aware that our 90-day supplies are really beneficial, again, when we have the longer, the patient has more access to the medication. They don't have to think about going in and getting it every 30 days. When they have a longer day supply of the medication, it's more likely to do it. And then really when we're thinking about different ways we're doing and we're thinking about taking care of those patients and decreasing those barriers. Cost is always something that can potentially come up for some of those branded medications. A lot of our manufacturers are having coupons and having opportunities for lower cost alternative. Sometimes even the generics are a higher copay, but some of the other coupon systems that are out there that are available for those lower cost medications could be lower for the patients. And then a lot of the pharmacies are either utilizing mail order or getting those medications delivered to the patient's home. Again, can't talk about management of these disease states with thinking about ways that they can be more adherent to the right medications at the right time. Next slide. Want to look a little bit at some of the medications. I know this is an eyesore, but I think that why I want to call this out is it really looks at the variety of different medications. And so specifically for our Medicare population, this is looking at how adherent some of those medications are. Again, some of those really have a very high adherence rate. And by and large, we're in that 76 to 80%. So just kind of giving a visibility in some of the medications that are currently being used, but and this is specifically Blue Cross Blue Shield North Carolina population, what we're seeing as some of the adherence for those. And on the next slide, again, very similar view, but again, this is looking at our commercial population, and we do see a little bit of a dip in that. So we see a far less adherent of those medications, and some of those branded medications are there, tend to be there on the bottom. And a lot of that has to do because of the cost, again, when they're getting those medications and having a difficulty, they're the tier 3 or tier 4, so higher percentage copays or a higher actual out-of-pocket copay for those. So this will be with you, but just kind of sharing with you some of the data we have as far as the specific medication classes and the adherence to those medications currently. Next slide. I want to talk really briefly also about glucose management indicators. So when we look at GMI, this was a new thing for me a couple years ago when it was put into the HEDIS measure, but it allows for different ways. So instead of always going through the A1C, a lot of our population are using continuous glucose monitors or CGMs. So it allows to take that data from a continuous glucose monitor and approximate what that A1C through calculations. I put the calculation here, but that's kind of a little bit difficult to to get there. But you can also see below there is a hyperlink for a calculator, so you can put some of the key factors in, what the 14-day average for the patient is, and then it'll help calculate what that GMI percent would be for those. Also on the left-hand side, the hyperlink for CGMs, again, a great tool, especially for currently our insulin-dependent population, or patients who have moved on to insulin as part of their medication regimen, even if it's type 2 diabetes. But there is CGMs, or continuous glucose monitors, that would be available for that population. Next slide. So as I wrap up my time with you and turn it back over to Nina to continue the conversation, I just wanted to do some of the key takeaways. Again, use your tools. You guys are really good at this, I'm sure. So how do we empower the patients? How do we think about creative ways to really help those patients? It doesn't always have to fall on us. There's a lot of people out there that are really trying to move towards helping to improve the outcome for all of our patients together. Medications, again, it's one of the options to help close the gap, but it's probably the most common ones to do. But getting them prescribing a medication doesn't always do it. We need to try to remove some of those barriers and try to improve adherence for those patients. And then wrapping it up with closing gaps, again, some opportunities for either in-home opportunities by utilizing continuous glucose monitors, the calculated GMI, if you don't have access to A1C as readily. But then also, there's some possibility for at-home blood pressure monitors where patients would be able to get those filled. And we do have those available through prescription in the pharmacies for both A1C testing as well as blood pressure monitors. That's something we started with the commercial population just this year. All right, I think I stayed within my 10-minute time frame, and I'll turn it back over to you, Nina.
Thank you so much, Brendan, for those very poignant insights, and obviously for the tools, right? We love tools and resources. We're now going to hear from our second keynote speaker, Miss Melissa Beatty of Aledade. Melissa Beatty, MPH, BSN, RN, CCM, has 20 years of healthcare experience as a registered nurse serving patients at the bedside through electronic case and disease management, and now serving independent primary care practices here in North Carolina as a senior practice transformation specialist with Aledade Population Health Management within our value-based care. Quickly became a passion after caring for many patients and conditions for which proper prevention and chronic condition management would have improved patient outcomes and quality of life. As a senior practice transformation specialist, Melissa is able to help private practices identify patients in need of care and attention, as well as transform their workflows to efficiently manage their populations. And now you see why we have brought in Miss Melissa Beatty from Aledade to share some of these best practices with us. Melissa, I will turn it over to you now.
Thank you so much for that introduction, and thank you for inviting me to speak today. Population health management and hypertension control is truly a passion of mine and of Aledade's, as you'll see when we go through the next few slides. So next slide, please. All right, so many of you are wondering, who is Aledade? Aledade is a strategic partner for navigating value-based care. Our mission is to build a healthcare system which is good for patients, practices, and society, which rewards practices for delivering high quality care while also improving the health outcomes of our patients and reducing overall cost. Aledade empowers our ACOs by providing the information and tools needed to deliver care, which aligns with the value-based care essentials. And as a practice transformation specialist, I'm the first line of support for my partner practices. And we have about 22 practice transformation specialists in North Carolina who all have their own assigned practices as well. But being the first line of support for our partner practices is where we bring data to evaluate performance. We assist practices with identifying any gaps or areas of improvement and creating a path to sustainable success. Next slide. Hypertension or blood pressure control is viewed within Aledade as one of the most effective ways to save lives within primary care and has been the focus of ours for the past couple of years. Next slide. For Aledade's Blue Cross North Carolina cohorts in 2024, all of our commercial ACOs achieved either a 4 or 5-star for an average rating of 4.66. And this is an improvement from 2023, where Aledade, North Carolina achieved on average a 4.33 across all cohorts. The Medicare Advantage cohorts achieved a 3.68 collectively, and they also continue to improve year over year. Next slide. First, before we dive into this slide, I do want to mention Aledade views hypertension control as a marathon and not a sprint. The work that we complete to support this, to support our practices, is for long-term hypertension control and being proactive with gap closure rather than focusing on a Q4 push to close these care gaps at the end of the year. We truly want to transform workflows so we have hypertension control all year and not just in Q4. So Aledade supports hypertension control in several ways. One is evaluating and supporting workflows with the assigned practice transformation specialist. We look at, what does your pre-visit planning look like? How do we address items at point of care? Are we measuring blood pressures accurately? Are we documenting blood pressures in the appropriate place in the chart? And what are the protocols to support elevated blood pressures? Aledade also supports blood pressure control in a variety of ways using our population health management tool called the Aledade app. In this app, there's a work list which surfaces patients with elevated blood pressures and have no timely follow-up scheduled. Our patients with elevated blood pressures have blood pressure tags. If their most recent blood pressure is moderately or severely elevated, a tag will be on that patient's profile, as well as a hypertension tag, which also surfaces that a patient has a past medical history of hypertension. Each practice also has a care gaps work list within the Aledade app, where the care gaps that we receive from Blue Cross are loaded into, and as well as any medication adherence care gaps. We also support practices by optimizing their EHR to ensure the data is documented appropriately and it makes its way to the payer. The team approach is heavily promoted within Aledade. Each practice team member plays a vital role in blood pressure control. Are they measuring that blood pressure accurately? Are we outreaching and scheduling those in need of a follow-up? Are elevated blood pressures communicated to the clinician in a timely manner? And do we have the appropriate referrals in place if needed? Aledade also provides an array of materials and resources, such as access to hypertension champions, which are actually practice transformation specialists who have a focus in hypertension control. They serve as a resource for their fellow practice transformation specialists within each market. We also have blood pressure toolkits, a red card workflow to help alert staff that patients need a recheck of their blood pressure, and then also access to our Aledade's clinical engagement team with our regional medical directors. And then lastly, we always include the patient, setting small, achievable, SMART goals, evaluating that medication management, and promoting self-monitored blood pressures as appropriate. Next slide. Providers also have access to evidence-based medicine guidelines through our Aledade Learning Hub. These best practices are for improving quality of care is to use evidence-based medicine guidelines. The clinical practice guidelines are developed by professional societies listed here. And the Learning Hub is a single source of all these guidelines, in addition to the people support that they have access to as well. Next slide. So as mentioned before, Aledade views hypertension control as one of the most effective ways to save lives. 2025 has been a year of improving our data and resources to assist our practices with transforming their workflows to achieve sustainable results year over year. And we are calling this our blood pressure boost. Next slide. We have a new tool called the Blood Pressure Control Profile, which provides actionable, data-driven insights into our clinicians' performance. This profile evaluates whether or not there is a pattern of rounding blood pressures up or down to a reading ending in 0. It also provides insights into how many patients with an elevated blood pressure either have or do not have a timely follow-up. And it also provides insights into clinicians' actions regarding medication management and whether or not clinical inertia may be a concern. Next slide. In addition to the blood pressure control profile, there's a targeted outreach and education to practices and providers where we have identified a large opportunity to improve blood pressure control. Targeted emails with data insights and educational offerings are sent to providers to raise awareness of the data and resources available to assist with improving metrics and improving patient outcomes. Next slide. Our next approach is motivating patients. Patient engagement is crucial to the success of our blood pressure initiatives. Alidate staff sends asynchronous outreach, which can consist of text or mailers, as well as completes direct phone calls to patients to schedule their next visit where we see an elevated blood pressure. We additionally have centralized patient-facing resources to ensure high-quality information is available to the patients. And I will add, for any medication adherence concerns, we also have a pharmacy team, which assists practices with outreaching to patients with open medication adherence care gaps. Next slide. Monitoring blood pressure with successful patient engagement and outreach effort is key to the success in this measure. Successful blood pressure control requires regular monitoring. We do provide free home blood pressure cuffs and remote patient monitoring to select practices. Additionally, we do enhance the hypertension work list to perform outreach. And when evaluating data, we have noticed that users who regularly engage with the hypertension work list have an 80% blood pressure control or higher. And then the Alidate way, which we continuously promote, is to have a timely follow-up with a patient when we see a blood pressure is elevated. And that timely follow-up should be within 2 to 4 weeks of that elevated blood pressure. Next slide. And then just as a recap, Alidate does support blood pressure control in a variety of ways. All practices receive support with mailers and text, along with practice transformation support and data. And then Alidate also uses a strategic data-driven approach for practices and cohorts in need of extra assistance, which may include the scheduling support, a specialist blood pressure workflow consulting, which we have a group of nurse practitioners and nurses that assist us with this, as well as remote patient monitoring support or chart reviews. Next slide. Next slide, please. And then that is it for me. Thank you for taking the time and to listen to me and learn more about how Alidate is working toward our mission of doing what is good for patients, practices, and society. Thank you.
Thank you, Melissa. Thank you so much for that information. Love seeing and hearing all the great work that Alidate is doing. We are now going to switch and have a member of our quality provider engagement team, Ms. Kelly Jacobius, to talk to you all about a few of our measures here for our end of the year sprint. Kelly, turning it over to you.
Okay, thank you, Nina. Good afternoon, everybody, and thank you for sharing an hour out of your busy day taking care of our members to be with us today. With my presentation, I will be reviewing the following: the NCQA HEDIS measure descriptions for both GSD and CBP. I'll be providing some insight with our 2025 provider reference guide. also sharing North Carolina statistics trending for both these measures, and some Blue Cross gap closure rates statistics as well. And then finally reviewing common barriers within a practice setting that may cause open gaps, followed by practice-wide strategies for success along with resource information. I will be calling out key areas within the presentation. You will receive a copy of these slides to use as a reference. And I have included our quality management email should you need further support from our team of quality management consultants. Next slide. This slide represents the NCQA HEDIS measure specification description for controlling blood pressure. Some key points is understanding the age of population that pulls into this measure, the time frame for this measurement year, the clinical goal, the measurement year goal, and the required exclusions and gap closure codes call out. Our 2025 provider reference guide is included as a hyperlink in a later slide, which is important to have to see a summary of this measure slide along with the required codes, both for gap closure and exclusion codes. The most recent blood pressure of the year must be less than 140/90 in order to close this gap. It is critical to repeat blood pressures during the same day visit should the first be non-compliant. You can use the lowest systolic and lowest diastolic blood pressure reading to report via claims or extracts. It's also important that for members either newly diagnosed with high blood pressure or a change in medication for their blood pressure, that follow-up visits are scheduled to check their blood pressures as part of your workflow. Lastly, blood pressure readings taken by the member with a digital cuff and documented in the member's medical record are eligible for use in reporting. You will need to ensure that these readings are submitted via claims or extracts. We do not accept controlling blood pressure medical records in Blue eCDX for gap closures. Next slide. Okay, so this is the CBP measure call out on this slide is from our 2025 provider reference guide. Please note the lower right highlighted box, which includes the codes you will submit for reporting blood pressure values. The provider reference guide will be your resource to review the CBP measure information along with the codes to use to close care gaps along with submitting exclusions. Please note that your QMC is not a certified coder and cannot inform you how to code on your claims form. You'll need to refer to your practice coders. Next slide. For CBP, early detection matters along with the importance of working with the member on controlling their blood pressure. Early detection can catch hypertension before it causes damage and can save lives by significantly reducing cardiovascular disease mortality outcomes, while also decreasing billions in healthcare costs by preventing complications. Next slide. The data on this slide is from the U.S. Department of Health and Human Services Centers for Disease Control and Prevention from 2023. On the left side of the slide, it reports that 37.5% of North Carolina adults report being told by a health professional that they have high blood pressure. North Carolina is ranked 38th overall out of 50 states for high blood pressure. And on the right, you'll see the trending is showing that North Carolina is trending higher than the United States. Next slide. Now we'll discuss our second measure, the glycemic status assessment for patients with diabetes. This slide represents the NCQA HEDIS measure specification description for GSD. The slide describes the key points of this measure similar to CBP callout. We're referring to the acronyms of GSD and HBD as the GSD is the current measure, and we are using both in transition as the HBD no longer exists since the start of 2024. The HBD in terms of measure abbreviation has been used in manuals or policies you have received in 2025. However, the HBD measure no longer exists as the start of 2024, and we're using them together this year through this transition. The only difference in these two measures, GSD and HBD, is that with GSD, providers now have the option to use a glucose management indicator, or otherwise referred to as GMI, along with an A1C. GMI values can only be submitted by extracts in medical records, whereas HBD can be submitted via claims, extracts, and medical records. The goal for our commercial marketplace members is to have the most recent glycemic status, A1C or GMI, of 7.9% or less, and for Medicare members, a glycemic status, A1C or GMI, of 9% or less. For Medicare, this is an inverted measure rate. Greater than 9% it's reported as greater than 9% is a lower reported rate for better performance, better diabetic care. However, on our Blue Cross reports, we choose to reflect this rate as the actual clinical goal of less than 9% to align reporting of both glycemic static rates and reduce confusion of the clinical goal. Next slide. This is another snapshot of the GSD measure as shown in our provider reference guide. And again, just please note what is boxed in red are the value set codes that you will submit to report values. Next slide. For GSD, monitoring blood sugars aids in the prevention of serious issues like heart disease, kidney failure, nerve damage, and vision problems. It empowers members to see how their choices affect their glucose levels in order to encourage a sense of control. It helps you as providers to assist our members with education, adjusting medication, diet modifications, and real-time data. Go to the next slide. This data on this slide is also from the U.S. Department of Health and Human Services 2023 for diabetic trends. North Carolina as a state ranks 32nd out of 50 states for diabetes, and 12.4% of adults 18 and older who reported ever being told by a healthcare professional that they had diabetes, which excludes pre-diabetes and gestational diabetes. A similar call out like CBP is that the North Carolina population of diabetics trends higher than the US overall. We can go to the next slide. So next I'll be sharing a comparison between Blue Cross North Carolina commercial and Medicare gap closure rates for both these measures. We can move to the next slide. This slide is comparing commercial 2024 final CBP and GSD gap closure rate percentages and July 2025 year-to-date gap closure rates. The final 2024 data is included beneath both bar graphs. The table on the left is our Blue Cross North Carolina Premier members, and the table to the right is all Blue Cross North Carolina members. The red line graph represents July 2025 year-to-date gap closure rate, and the green is the 90th percentile benchmark, an important goal to strive for. The call out on this slide is showing that the tailored service through our incentive programs are showing a higher gap closure rate on the left in comparison to all Blue Cross members on the right. We appreciate your hard work. Next slide. This slide is similar to the slide just shown before, representing, though, our Medicare gap closure rates. And the message still is that the tailored service through our incentive programs are showing a higher gap closure on the left in comparison to all Blue Cross members on the right. So let's shift gear and explore the core insights driving today's discussion with Q4 Sprint and beyond. Next slide. Practice-wide alignment in primary care refers to a unified strategy where every part of the practice represented in this hexagon display works in sync to deliver consistent, high-quality care. Patient engagement is key, as Melissa shared earlier, and patient empowerment, as Brendan also shared. When this happens, the outcome of member open care gaps will improve. However, not every practice has the bandwidth to have all these varied positions. So in these cases, you will have to divide and conquer the work along all your staff and identify your staff champions in your office who can lead efforts to improve quality care during Q4 sprints and beyond. Next slide. With working with practices over the years, we have identified 4 common workflow barriers that can hinder efficiency, patient outcomes, and ability to close care gaps. They are clinical and documentation issues, workflow and process gaps, member-related challenges, and limitations of data and reporting. Identifying these barriers initially may take some work. However, mapping workflows is important to identify bottlenecks and redundancies in order to eliminate more burden and duplicity of work on your staff. I know this is a lot of information, yet this is a guide you can utilize in your team huddles to identify barriers within your practice workflows with these 2 measures. Next slide. A successful tool when sprinting to the end of 2025 is creating sprint themes to use in your team huddles. These are just 2 examples. This can motivate your staff. When you create a successful, repeatable workflow designed to close gaps successfully. Excuse me. Next slide. So with the previous slide that I showed on common barriers, once you've identified your practice barriers, you then can define your practice-wide alignment strategies for a successful gap closure with the 5 strategies listed on this slide, which are weekly team huddles, EMR optimization, standing orders, outreach campaigns, and end-of-year push. Once practice strategies are incorporated into your daily practice, it's important to revisit them and track them to ensure that the enhanced workflow is smooth sailing. Next slide. These are 3 ways you can close care gaps. Claims and extracts are the best choice, and medical records is more limited in which measures you can submit for gap closure. And please note that the deadline for medical records is November 15th, 2025. GSD is an acceptable medical record to submit by the deadline. However, CBP is not accepted as a medical record for gap closure, only through claims and extracts. Medical records for purposes of gap closure are to be uploaded into Blue CDX following the exact naming convention in the medical record guidelines, or you could risk the chance of them being rejected. If you need a copy of our guidelines, please reach out to our quality management email to request them. Next slide. So we discussed common barriers and then practice-wide alignment strategies. How will your practices sprint successfully to the end? Have you identified practice champions? How will you start strong Q1 2026? By reviewing the barriers identified, you can develop workflows to ease the burden of your day-to-day operations. And as QMCs, we're here for you. The next few slides are just reviewing resources your practice can utilize. We can go to the next slide. So listed on this slide are important numbers for you to be aware of. Should you as a provider feel that your patients need more support for their high blood pressure or diabetes management, then you can contact our case management team at the numbers listed to request enrollment. But also note that members can also self-enroll too. I've also included the Blue Cross North Carolina eSolutions phone number and the provider Blue line. Lastly, it's important that all members of your staff sign up for the provider news email newsletter, as it provides up-to-date information on various subjects that impact your practices, such as billing and reimbursement, incentives, behavioral health programs, and many more subjects. Throughout our presentation today, you've received a lot of valuable information as it relates to the importance of CBP and GSD screenings, as well as the ways in which one of our ACOs has shared their workflow efforts to close these care gaps. So for further guidance and education on gap closure efforts, we encourage you to explore our provider reference guide using the clickable link within this slide. Next slide. Our medical record submission guidelines for care gap closure is available to you, and if you need a copy, you can email us at the email listed within this slide. We already talked about this. However, please remember we do not accept CBP records via Blue CDX, and the medical record deadline for GSD HBD is November 15th. We can go to the next slide. This is a resource guide for correct measuring of blood pressure in office and at home, and this is from the American Medical Association Measure, Act, and Partner Hypertension Program, and it was developed to help to improve practice and patient outcomes. The picture to the left is to support education to your patients on how to measure blood pressures from home. The snapshot on the right is to reinforce with your staff that accurate blood pressures are obtained during member visits. And you'll see beneath these two pictures are several resources from the site that you can use for patient education along with staff training. Next slide. At Blue Cross North Carolina, the Tier 6 list shown here is to make sure members can get the most out of every healthcare dollar. For Blue Medicare HMO PPO members, they can take advantage of zero copay in-network preferred pharmacies or a low copay at an in-network standard pharmacy on the range of commonly prescribed drugs such as generic drugs for high blood pressure, high cholesterol, and diabetes. Use this list to ensure our members, your patients, are getting the best value from their pharmacy benefits. And then lastly, Safe Ride is a benefit to our Blue Cross North Carolina Medicare Advantage members, with the exception of Blue Cross North Carolina Medicare Essential Choice HMO, who are excluded from this benefit. Safe Ride is a benefit providing rides to appointments and pharmacy visits. For questions concerning benefits for our members, please contact our provider Blue Line at the number presented previously. Just want to personally thank you for your time today, and we appreciate the ongoing care you give to our members. We know that you're managing a lot in your day-to-day operations, and we're here to help you. So please reach out to your QMC, or you can email us at our quality management email. I want to thank you.
Thank you so much for that information, Kelly. I'm hoping that everyone's toolboxes are full now, right? As well as their thinking cap's been fired up due to the information that Melissa of Aledade shared. At this time, we are going to open the floor up to any questions that anyone may have in the chat. We do not have any updates for this particular webinar, as this is our last webinar of 2025 from the Quality Provider Engagement team. So I will ask Ms. Kylie Longoria if we have any questions in the Q&A section.
I need to know we do not.
Okay, great. Thank you so much for that. We are right on time here for everyone. As mentioned before, if you do have any questions for any of our presenters that maybe you can't think of now and you can think of later, please do email us at quality.management@bcbsnc.com. But while we do have a few more minutes of your time allotted for, we do ask if you have your smartphone available, if you could, if you have your smartphone available, if you could please scan the QR code on your screen, or within the Q&A section, there is also a link to this particular survey. We ask if you can complete that survey. I do see one hand up. It looks like from Ginger Pugh. Ginger, did you want to ask a question? Let's see if I can get you off of mute here. I am not able to get you off of mute, Ginger, so I'm going to ask if you have a question, if you could please put it in the Q&A section. We do have time, so please don't feel rushed. While we're waiting for that question to